So with the PCAB option for H. pylori, I mean, it seems like that would be most helpful, or that class would be most helpful if acid suppression was the main reason for refractory HP. But if it's really the antibiotic choice or resistance, you think that, I mean, I guess the jury's going to be still out, but, what's the goal there?
So, I think that's why the study was important, because they really had the same antibiotic components.
Right.
So the theory behind its increased efficacy, yes, there may be more potent or prolonged acid suppression allowing healing, but not necessarily eradication. So I do think that there's something inherent with regards to allowing those antibiotics to hang out longer, be more effective, and also drive that H. pylori into a more susceptible state. And I do think that that's inherent in this combination with the PCABs, and I think that's going to be a game changer over the next 5 to 10 years, probably.
Great, thank you. Yes, please. First question.
Regarding refractory PUD, you had a list of medications that obviously we all know, the NSAIDs, steroids, but you had olmesartan there, which is antihypertensive. Considering that half of Americans, or at the age of 40 or 50, are taking blood pressure medications, I didn't realize that this was, is this a major problem? Because
it's not a major problem, but it has been associated with refractory ulcer disease. So it's something to think about in the right clinical scenario in that individual patient. So I did not mean to imply, and hopefully I didn't imply, that if somebody has an ulcer, they have to be taken off their olmesartan, because they don't. But if you have somebody who, and again, I put those numbers up there, 5 to 10% of ulcers are deemed to be refractory. That's not what I encounter in my clinical practice. I think it's 1%, if that. So this is still a relatively, I think, rare phenomenon, but in that appropriate scenario, it might be something to think about. I'm much more concerned about continued or unconscious NSAID use and other factors besides olmesartan. It's low on the list of things that I would think about.
Good. I don't want to have to choose between an upper GI bleed or a stroke,
Yeah. We don't want either one. Second microphone, please. Go ahead. Back there.
Sure. Hi, thank you for all the information. So for H. pylori, for patients that either don't tolerate the antibiotics or are allergic to a ton of antibiotics and just refuse to take any more, do you keep them on a PPI? Do you keep them on an H2 blocker indefinitely, or what's the approach?
I try not to use chronic H2 blockers because I don't think they're very effective, period. I do think that they can sometimes help patients with nocturnal symptoms. I don't know if that's a placebo effect or real. The answer about PPIs is yes, I keep them on chronic PPI. I also will send them to the allergist and verify their allergies, because there's pretty good data that suggests that most of the penicillin allergies are not penicillin allergies, and you can get those, and in that case, it's reasonable to try very high dose amoxicillin, which is generally well tolerated, and a PPI, just dual therapy. You get away from all the nasty tetracycline side effects and metronidazole side effects. So if you can talk somebody into that, and the rates of those resistance to amoxicillin is still very low. You may have to prolong that therapy, but those are patients where I would let sensitivity testing drive which antibiotics I use, and having that available now, I think we're going to be more able to craft regimens that patients will tolerate and adhere to. But it is a very legitimate point that you raise. I will keep them on chronic PPIs.
My second question, sorry. For PPI responsive EOE, also, do you keep these patients on PPIs just kind of indefinitely, or do you go through some of the other motions like 6-food elimination and whatnot? Because I'm seeing a lot of patients that just, they respond to just the PPI without any, steroid or anything.
Yeah, and that's exactly what I do. I do try. I have a meet with my dietitian, and we do talk about diet, and we try to convince them to go to do some elimination. But if they respond beautifully and are asymptomatic and histologically they're in remission with a PPI, then yes, I just keep them on a PPI. And I'm going to jump back to the H. pylori, and I really try not to rest on non-eradication, because beyond just the peptic ulcer risk, remember, there's a real risk. It's not super high, but it's a real risk of malignancy. And And there's a few other conditions that H. pylori is associated with that are on the boards, like ITP and things like that we never really think about. But the risk of malignancy is real, and so I really try to eradicate that if I can. And there's good data that shows that you lower the risk of gastric cancer when you eradicate HP.
Thank you. Right. Go ahead, Sean.
Two things. First, Dr. Brooks, because we don't have PCABs yet, I've laid a 4-day lead-in with BID PPIs since we don't know that it reliably works as well as PCABs in 1 day to make people sort of achrotic than their 2 weeks. The other comment would be for Dr. Kunkel. I have a surgeon in my area that has treated a small series of severe refractory gastroparesis patients with a gastric sleeve, exploiting the 15 to 20 minute very rapid response. One lady that was a young type 1 diabetic, 70 admissions at Bethesda before she was sent to our small naval clinic in Port Hueneme about 4 years ago when I inherited her. And miraculously, in the hospital here 20 times, nothing for 3 years. I didn't believe it. I was very, very skeptical. He's presented it at SAGES 2 years ago at poster session, and I think he's going to publish that too.
Yeah, the sleeve gastrectomy does increase gastric emptying. I have a couple patients where we have had our minimally invasive surgeon perform sleeve gastrectomies. Again, really refractory cases, a lot of healthcare resource utilization. So there is published literature on that. It is certainly an option for, those Hail Mary type situations.
So that patient did better in San Diego than they did in Bethesda? It's hard to believe.
I've even had her there 6 years ago or 7
There's
years
no
ago. I'm
chance.
sorry to say that. You might have
probably
had
did.
one of the times happen.
That's what drove her to the West.
Your past comes back to meet you.
That's what drove her to the West Coast. Can I ask, David, what are your thoughts on, there was an interesting abstract that was presented at, I believe it was ACG, it may have been DDW within the last 2 years, from Texas Tech and McCallum looking at POEM as well as gastric electrical stimulation at the same time. So pyloromyotomy, I should say, let's use a general term. I think it was GPOEM, I'm not sure, it may have been surgical, but a combined approach as opposed to individual approaches. What's your thoughts on that?
Yeah, so Dr. McCallum has preached if the surgeon's going to go in to place a gastric electric stimulator, they're already in the abdomen, go ahead and have them cut the pylorus since, there are relatively very few downsides, dumping syndrome. And then Washington University implemented that, and they were saying, we're having much better outcomes as well. So I went to our surgeons and said, all right, let's try that out. And our surgeon said, we're worried about the lead getting infected if we do those two things at the same time. So they basically said, we're never going to do them at the same time because of lead contamination. We want the lead to set, scar, and if later you want this patient to undergo a pyloroplasty or pyloromyotomy, we'll do it at that time. So I was sort of blocked by our surgeons.
Yeah, and I did the same thing, and I work very closely with my surgeons and I respect them. They're great. I think they're wonderful surgeons, and their approach is to do a staged approach as well. They'll do the myotomy first, and if that doesn't work, then they'll come back and do the stimulator. I've not been very impressed with the stimulators by themselves. I don't know if you have or seen, wildly successful GES without a pyloromyotomy. I see some success, but it's often short-lived and may even be a placebo effect. I don't know.
Yeah, the stimulator is tricky because those patients are bonded with you for life. Yeah. So, you're going to bed here tonight and they're, traveling in Europe. And if there's an issue with the stimulator, you're getting paged right away. So, so there's certainly something that I reserve way at the end in terms of options. I don't jump to it. I don't yet have enough experience with that combo of stimulator and pyloroplasty to form my own opinion.
Yeah.
So we have one last question. Actually, sorry, before we get to your question, we have a question on the Zoom. It says fluticasone is recommended orally for treatment of EOE. If airborne allergens seem to be an active ingredient for agent for EOE, why not give the fluticasone nasally?
Because it may not be the only
Right.
etiology. So you still have to deliver some local therapy, we believe, to the esophagus.
Yeah.
So, you can certainly give fluticasone nasally for somebody who's got those
Allergic
kind of,
rhinitis.
yeah, those nasal symptoms or alert allergy symptoms, but they still need some local therapy to their esophagus. And it may not necessarily have to be a steroid. It may be a PPI. It may be reducing some of those foods. But you also want to try to prevent polypharmacy as well. But generally the swallowed steroids are well tolerated. Of course, we do have patients who get thrush, and it's a problem for some patients.
Sure. One last question.
Prostaglandins for intractable peptic ulcer disease. I've not done that, and I haven't seen any data on that. I don't know.
Great.
I don't know.
Well, thank you all very much. Appreciate your attention. Thank you to our